Welcome back to the Deep Dive. Today, we're zeroing in on a cornerstone of modern medicine, contraceptive pharmacology.
Right.
And we're going past the simple stuff, the pill versus the implant, going straight into the body's control room, the endocrine system. So our mission for this deep dive is to really take these complex source materials and distill the functional difference between the three major hormonal pathways.
Combination pills, the low-dose progestin-only pills.
And then the high-dose, long-acting methods.
Precisely. And this dive is about understanding mechanism, risk, and I think critically, compliance.
Right.
When we compare these three, we're not just looking at ingredients. We're contrasting, systemic hormonal suppression with physical barrier reliance.
And what you call long-term hypothalamic jamming.
Exactly. We need to identify how they work, but also where the absolute lines are drawn, especially when estrogen is in the picture.
Okay, let's dive into the foundation then. Combination oral contraceptives or COCs.
The classics.
These were approved in the U.S. way back in 1960, and they're built on that duo of hormones, an estrogen, usually ethinyl estradiol, and a progestin.
And right away, this is where we see that gap between lab efficacy and real-world efficacy.
The perfect use versus typical use.
Exactly. If a woman takes these pills flawlessly, what we call perfect use, the pregnancy rate is tiny, less than 1 woman in 100 per year. It's incredibly effective.
But the second you introduce reality, you forget a pill, you take it a few hours late.
That typical use failure rate just jumps.
Yeah, we're suddenly looking at 2 to 8 women out of every 100 becoming pregnant in a year.
It's a huge drop in efficacy.
And it's due purely to human nature.
It is, but what's so remarkable about COCs is that they're built with a kind of redundancy. They don't just rely on one function. They have this triple mechanism of action.
Which makes them a bit more forgiving if you miss a dose by a few hours.
Exactly.
Like a multi-layered defense system. So what are those 3 layers?
Layer 1, and this is the main action. They inhibit ovulation entirely.
Just stop it cold.
Stop it cold. Layer 2, they dramatically thicken the cervical mucus.
Creating a physical barrier.
A really formidable barrier against sperm. And then layer 3, they thin the endometrium, the uterine lining.
So even if a fertilization somehow happened, it would have a very hard time implanting.
Correct. The likelihood drops way down.
That redundancy is really the key to their forgiveness. Okay, let's zero in on the pituitary gland because that's where all the hormonal warfare really happens. What's the specific role of the estrogen component in this strategy?
You can think of the estrogen as the primary signal dampener aimed at the brain. Its role is really twofold.
Okay.
First, it decreases the pituitary gland's sensitivity to gonadotropin-releasing hormone, or GnRH.
And second?
And this is crucial. It inhibits the release of follicle-stimulating hormone, FSH.
So without enough FSH, the body can't even select a dominant follicle to begin with.
Exactly. The entire preparation for ovulation just stalls right there. It's like stopping the race before the runners even get to the start line.
And once the track is quieted by estrogen, the progestin component, the synthetic progesterone, comes in.
It comes in to make sure it stays quiet.
Right.
The progestin in COCs ensures that even if a signal tries to get through, it fails. It has this powerful inhibitory effect on the luteinizing hormone, the LH surge, that would normally trigger the egg release.
So the estrogen handles the FSH, and the progestin handles the LH surge.
Precisely. The net result is that plasma levels of both are suppressed, the mid-cycle surge is completely absent, and there's no ovulation. It is, like you said, a pharmaceutical checkmate.
That makes the mechanism crystal clear. Now, speaking of delivery, the source materials mention variations like monophasic, biphasic, and triphasic pills.
Right.
Why complicate things with different dosing schedules?
Well, these variations are really about fine-tuning the hormone exposure over the cycle.
Okay.
Monophasic pills deliver the exact same dose for all the active days, so it's a very steady state.
And biphasic and triphasic?
They adjust the hormone ratios mid-cycle. This was originally done to try and mimic a more natural cycle or maybe to minimize certain side effects for some women.
But the core mechanism is the same.
The core mechanism, ovulation inhibition, is absolutely the same across all of them.
And just to be clear, those placebo pills in the pack, the sugar pills, they're just there to keep the user on track.
Primarily, yes. It's a compliance tool. It keeps that daily habit going so you remember when to start the next active pack.
Yeah.
Pharmacologically, they're inert.
Though some have iron supplements, right?
Some do, yes, to address potential blood loss. But no active hormones for contraception.
Okay, but here's where it gets really interesting. The major trade-off for this highly effective, redundant system If COCs are so robust, why can't everyone take them? And this brings us to the pretty serious risk profile of the estrogen component.
This is a crucial distinction to make. While the vast majority of women do just fine on COCs, estrogen, especially synthetic estrogen, it changes the body's clotting chemistry.
Right.
So the serious risks are all related to hypercoagulability,
An increased tendency for blood to clot.
which can lead to deep vein thrombosis, heart attacks, strokes, very serious events.
So for a small but significant group of women, COCs are just too dangerous. We should probably be really clear about the absolute contraindications.
Absolutely. The lines are drawn very strictly here. If a woman has a previous history of any thromboembolic phenomena,
So any past issue with serious blood clots.
any at all, COCs are out. Same for any cerebrovascular disorders like a stroke, and for any estrogen-dependent cancers like certain breast cancers.
And liver dysfunction is on that list too.
Active liver disease or dysfunction, yes. That's also a complete ban.
You know, the one that often surprises people is migraines.
It does. Migraine headaches, especially migraines with aura, are treated with extreme caution
Why is that?
because they can indicate an underlying vascular sensitivity. And when you add estrogen, which promotes clotting, you can significantly increase the risk of an ischemic stroke in that vulnerable group.
And then there's the risk that gets repeated over and over, yet so frequently ignored.
Smoking.
We really cannot overstate this.
No.
Smoking, all by itself, causes vascular damage. When you combine that with the hypercoagulability from estrogen, the risk just explodes.
The sources say a 3 to 6-fold increase in the risk of blood clots.
A 3 to 6-fold increase. It's massive. It's why providers are so emphatic that COCs and heavy smoking are fundamentally incompatible, especially for women over 35.
And the risk is so high that women are advised to stop the pill a month before any major surgery.
A full month, yes, just to manage that clotting risk.
That is a really powerful illustration of the danger. And it takes us directly to the patients who need effective contraception, but absolutely cannot touch that estrogen risk.
Exactly. This leads us to the progestin-only path.
The so-called mini pills.
Yes, the low-dose progestin-only mini pills, or POPs. These are the solution for breastfeeding women, for smokers, or for those with risks like hypertension or a history of clots.
Because they have no estrogen. No estrogen at all. Which means they carry no evidence of increasing thromboembolic events or high blood pressure. They're a much safer choice for those high-risk groups.
Okay, so let's break down the mechanism of these low-dose POPs because they operate on a completely different principle.
A totally different playbook.
They don't really rely on suppressing ovulation in the same way.
Not reliably, no. That's the critical difference. The dose is so low that POPs only manage to stop ovulation in about, say, 60 to 80% of cycles.
So not every time.
Definitely not. They just don't have the hormonal firepower to reliably shut down that pituitary cascade every single month.
So if ovulation is still happening most of the time, the defense has to shift somewhere else.
It shifts entirely to creating physical barriers. Their primary mechanism is to dramatically thicken the cervical mucus.
So it becomes a security guard at the entrance of the uterus.
A very effective one.
Right.
The mucus becomes so viscous and hostile that sperm just can't get through. Their secondary action is altering the endometrium, but that mucus barrier is the real star of the show.
But this is where compliance becomes a nightmare scenario, right?
Mm-hmm.
The sources stress that this mucus barrier isn't permanent. It's very time sensitive.
This is the absolute crux of why the failure rate is what it is in typical use.
Okay.
The low-dose POPs create that thick mucus within about 2 to 4 hours of taking the pill. But because the dose is so low, that barrier starts to break down and thins out after 24 hours.
So if you're even just a couple hours late taking your pill.
The security guard has gone home. The barrier is essentially gone.
So we are literally talking about setting a phone alarm and needing to stick to it within like a 1-hour window every single day.
Exactly. If you get stuck in traffic or you sleep through your alarm and that window closes, your main contraceptive mechanism just evaporates for that cycle.
Wow.
So it trades the hormonal certainty of COCs for safety from estrogen, but it introduces this enormous compliance burden.
Which is why their effectiveness depends so critically on user discipline. That transition is perfect. So if the low-dose POP introduces this massive compliance challenge, is there a way to solve the estrogen risk, but keep the efficacy of guaranteed ovulation suppression?
Yes. And that brings us to our third path. the high-dose, long-acting progestin solutions.
Yeah.
These are the methods where we increase the progestin dose substantially, much higher than the mini pill, and then deliver it continuously.
Through an injection or an implant.
Exactly. And this high concentration is designed to restore that systemic efficacy.
So how does high-dose progestin shut down ovulation so reliably when the low-dose version can't?
The mechanism shifts again. These formulations give you a relatively high plasma concentration of progestin, and that is able to effectively jam the brain's master clock, the hypothalamus.
Ah.
The high progestin levels cause a dramatic decrease in the frequency of GnRH pulses coming from the hypothalamus.
So it's not just negative feedback anymore. It's signal suppression right at the source.
Correct. When those critical GnRH pulses slow down or stop, the pituitary gets almost no command to release FSH or LH.
Which suppresses the whole cascade.
The entire cascade. It prevents ovulation in virtually all patients, and that guarantees high efficacy without worrying about daily timing. The drug is just in your system for months or years.
Okay, let's look at the two main options here.
First, you have the depot-medroxyprogesterone injection, or Depo-Provera. This is an injection either into the muscle or under the skin that provides contraception for a full 3 months.
And it's highly effective.
Very. Only about 3% of typical users become pregnant in a year. Second is the etonogestrel implant, known as Nexplanon.
That's the little rod that goes in the arm.
A thin, flexible rod, yes, inserted under the skin. It provides continuous, uninterrupted contraception for up to 3 years.
And the sources note that it's radio-opaque.
Yes, which is a nice feature. It means it can be easily located by an X-ray or CT if it's ever difficult to remove.
So because these methods rely on systemic suppression over a long time, there's naturally a different trade-off. What's the major adverse effect specific to these high-dose methods?
The primary concern, especially with Depo-Provera, is time-dependent bone loss, osteoporosis.
And why does that happen?
It's a direct result of that extreme suppression of the pituitary axis, which also lowers the body's own natural estrogen production. And reduced estrogen impacts bone density over time.
So it's something to be monitored.
It is, especially with continuous long-term use.
But just to confirm for the listener, someone with that history of DVT who can't touch estrogen, these high-dose progestin methods are generally considered safe alternatives.
Absolutely. While you might see some legacy warnings on package inserts, both the CDC and ACOG confirm that methods like Depo-Provera and Nexplanon are acceptable for women where estrogen is strictly contraindicated.
So they solve the compliance problem and the estrogen problem at the same time.
Exactly.
So we just, connect this to the bigger picture. We've really dissected 3 entirely different hormonal strategies today.
We have. We started with the combination pills, which rely on that powerful systemic feedback and redundancy. Ovulation shutdown plus a mucus barrier. Then we moved to the low-dose mini pills, which give up reliable ovulation suppression and rely almost entirely on that mucus barrier, which demands precision in timing.
And finally, the high-dose, long-acting formulations,
which use that continuous high concentration to jam the hypothalamic signal, achieving maximum duration and efficacy totally independent of daily timing.
But despite these different paths, they do share some common non-contraceptive side effects that listeners should probably be aware of.
Yes, that's a good point. Across all methods that manipulate sex hormones, common complaints often include headaches, mood changes, breast tenderness, nausea.
And breakthrough bleeding is a big one, right? Especially with progestin-only methods.
Yes, unpredictable menstrual patterns are very common and are often cited as a reason people stop using them.
So what does this all mean for you, the person trying to choose a method?
Well, you really have to view contraceptive choice as a transaction. It's a deal you're making with your body and your lifestyle. The effectiveness of a method isn't just its chemical design, it's its tolerance for error. A COC has that built-in redundancy that forgives you if you're a little late.
Whereas the low-dose POP has 0 error tolerance.
None. It demands meticulous, precise timing because its primary mechanism literally disappears within 24 hours.
So the real question isn't which pill is best in a textbook, but which mechanism is best designed to tolerate your specific daily life.
That's it. When you choose contraception, you're choosing how much compliance risk you're willing to bear against a specific hormonal risk profile.
And if your life is chaotic, A method that requires high precision is probably going to fail, no matter how great it is pharmaceutically.
Exactly. That gap between perfect efficacy and typical efficacy, that is what defines the real-world success of any of these methods.
And that's the conversation every patient needs to have with their provider.
Matching the mechanism to the daily reality.
Absolutely. It's a powerful reminder that pharmaceutical knowledge is only half the battle. The rest is just behavioral science.